Hello, and thank you for joining us for this MS Focus teleconference. I'm your host, Casey Minnis, Director of Communications for the Multiple Sclerosis Foundation, and I'm joined today by Patty Bobryk. Patty Bobryk received her physical therapy degree from Wayne State University in Detroit, Michigan, and her master's degree in neurodysfunction from the University of Florida. She was an integral member of the team that established the MS Comprehensive Care Center for Orlando Health in Orlando, Florida, where she provided rehab services for persons living with MS for over 25 years. Most recently, she's caring for individuals with neurological conditions at Yampa Valley Medical Center, a part of the University of Colorado Health in Steamboat Springs, Colorado. She's an assistive technology professional, assisting patients in obtaining complex rehab technology, and has been an MS certified specialist since 2004. Patty's services to the MS community include being an active member of the National MS Society's Healthcare Provider Council for Colorado and Wyoming, co-chair of the International Organization of Multiple Sclerosis Rehabilitation Therapists, and the treasurer for the executive committee of the Consortium of MS Centers. She received the Consortium of MS Centers ARDI Award for Excellence in MS Rehabilitation Care in 2018. We're very honored to have her with us today to discuss managing your MS symptoms with rehab. So now I will turn it over to her. Patty Bobryk, please take it away.
Thanks so much, Casey. I'm so pleased to be here with you virtually. I first have to give a big shout out to the MS Foundation. Would like to just take that minute and just acknowledge the difficult times that everybody's going through, and the MS Foundation has done just such a superb job at providing quality education in a means other than we're used to, and that's in person. So I'm really happy to be part of this program that they're offering, and hope everyone is staying well and safe. So I am coming to you from beautiful Steamboat Springs, Colorado. I've been out here a year. I spent many years in Orlando, Florida, working at the Orlando Health MS Center. So my shout out to all my colleagues and friends and patients in Orlando and across the country. So I have the pleasure to talk to you today about managing your MS symptoms with rehab. And so we're going to get right into it. We'll take some questions at the very end. So if you have something that you want to ask, hopefully we'll get to it and address that at the very end. So let me just take a minute because I want to talk about MS rehab. MS rehab is a little bit different than how you usually think about rehab. And there's a couple key points. One of the things that I want to bring out is that, you know, if you've sprained your ankle or you've had an injury that is taking you to rehab, and I'm a physical therapist, so that's kind of my slant, but if you're going to rehab for an injury like an orthopedic injury, the physician probably will write, you're going to see the therapist 2 or 3 times a week for 4 to 6 weeks. You're going to recover from your injury, and then that's the end of it. Then you're done with your rehab. And you usually see one member of the rehab team. How MS rehab is different is that it's usually multidisciplinary, and that's how it's best delivered. You want to have your team, your rehab team. So usually when I talk about the rehab team, it's physical therapy, it's occupational therapy, it's speech therapy, but there is a larger team. You know, there will be exercise physiologists and physiatrists. So, you know, your core team may be your PTOT speech pathologist, but the team is actually bigger than that. I always suggest that if you're shopping around for your rehab professionals, you try to find somebody who is knowledgeable in MS. And I got to tell you, we're kind of a rare breed, but there's more of us who are interested and passionate about treating individuals living with MS. There is an MS certification exam, so you can look for somebody in your area who might be an MS certified specialist. That's one way to connect. Certainly calling your service organizations like the MS Foundation or the National MS Society or MSAA, they have an idea who in the communities is doing MS care. So it's important to kind of get your team together and get your team together early. You might not need them, but on an ongoing basis. But if you have that connection, you're already established. So that's the next point. MS rehab care is different because it's usually intermittent and ongoing. Unfortunately, we don't have a cure for MS yet. And so you're living your entire life with this diagnosis. So you might need your rehab professionals every now and then. I actually suggest, and I usually recommend, that you check in with your rehab professionals like you check in with your physician. So, you know, whether it's every 6 months or every year that you go back and you get reevaluated so that your rehab professional can kind of what I call nip problems in the bud. You can get reevaluated and find out if there's anything that's minor going on that we can be proactive and prevent problems from occurring and becoming larger down the line. And the goal always for rehab is to improve and maintain function. Function is what it's about. We will talk a lot today about exercise, but it's always directed at some functional skills. So, you know, it's important to have a dialogue with your rehab professionals to tell them what your goals are and what's important to you. So it may be, I want to work on my walking skills or my balance, or maybe it's stair climbing, or maybe it's staying in the workforce or driving. But it's really important to have that conversation so that your rehab professional can work on those things that are most important to you. So rehab can improve mobility, and most people, when they think of mobility, they think of walking. But mobility is a very larger term for any movement that takes you from point A to point B. So mobility includes transfers, mobility includes getting to and from work or to and from school. It's up and down from the floor, it's climbing stairs, all of those things. So, you know, when you think about moving around, it's not just, okay, can I get from my bed to the bathroom, but can I move around my house? Can I move around my community? Rehab can also help with your ADLs, which stands for activities of daily living. And you can think of those as all of those things that you need to be independent in to kind of take care of yourself. So we're talking about showering or bathing, cooking, eating, hygiene, toileting, all of those basic skills. There's also IADLs, which stands for instrumental activities of daily living. And those are bigger things like in the community, driving, getting to work, being successful in work, school, or whatever activities. It might not be work or school, but it might be volunteering, or it might be going to church or to community activities. So ADLs and IDLs. Also, and there'll be a theme throughout my talk this afternoon about quality of life. It's important to be able to have the skills that you need, but those skills kind of float over into how you feel about how your life is going. Do you have a good sense of solace or peace about how your life is going? Are you satisfied with where your life is? Do you feel successful and completed? So a lot of what we do in rehab kind of floats into that, you know, better mood, better emotional state, better quality of life. I've already talked about this, that we can help in rehab prevent complications. And a good example of that, I've used this frequently, is let's just say you have a little bit of weakness in your ankle and foot. You've got a little bit of foot drop, but you're doing good. Your walking is really quite fine. You might, you know, kind of catch your toe every once in a while when you're tired. But if we don't address that early on, what might happen is that you might start doing compensations at the hip. You might start hiking your hip up, which will throw your back out. So ultimately, you might end up with a back problem because you had a little weakness at your foot. So being able to identify those things and being proactive about them early on is really, you know, part of what my job is and part of what your rehab team should be doing for you. Decreasing healthcare utilization. particularly when you have a cohesive team, you know, your rehab professionals can help kind of triage and help you problem solve a lot of things. The example that comes to mind is that quite frequently somebody will come to me and they'll say, oh, Patty, my symptoms are really much worse today. I don't know what's going on. Do you think I'm having an exacerbation? And as we talk about it and ask the questions that we need to ask, a lot of times we find out that, oh, you're having symptoms of a bladder infection. So we can connect with your physician and get a urinalysis done to see if that really is the case. Whereas if we weren't on top of that and it ended up being the weekend, you might have ended up in the ER over the weekend because your symptoms got so worse and your urinary tract infection went unchecked. So things like that, we can really help triage and help kind of connect you before they become too problematic. And we're always looking for safety and independence. We want you to be as independent as possible, be able to do all the things that you want to do, whether we have to look for compensatory or modifying strategies, but always getting you being able to do what you want to do. So that all sounds well and good, right? But there are some challenges that, that you're facing. One, right now, we don't have a cure for MS, so it's a chronic illness. So you're dealing with this across the span of your lifetime. But again, if you're having a cohesive team, they get to know you over the course of your lifetime. I knew people in Orlando. I was there for 26 years. And I treated people for 26 years, not continuously, intermittent and ongoing. But you know, you get to know that person really well, and you're able to kind of make the right connections and make the right decisions for them because you know them over the course of the time. The course of MS is variable. Those of you who are living with MS know that. You know, there's a lot of well, what's next month going to hold for me, or, you know, a lot of variability between individuals. So, you know, it's kind of our natural instinct to kind of like, oh, they have MS also. What are their symptoms and how are they doing, and wanting to compare yourself. But there's so much variability in this diagnosis that I can tell you, out of the thousands of people that I've seen with MS, although people have had similar symptoms, nobody's course has been exactly the same. So that can be challenging because there's just not a lot of certainty in that. And then again, there are invisible symptoms. I can't look at you, somebody can't look at you and say, oh, I know exactly how much fatigue you have, or I know exactly how much cognitive issues that you're having, or how much pain or sensory symptoms that you're having. So all of those things that are not outward becomes very challenging. You know, if I break my arm and I'm wearing a cast, that's a very outward sign of something's wrong with me. But many of the symptoms that individuals that are living with MS are facing are invisible. So it's hard for people that don't understand the disease to kind of wrap their head around that. Of course, you know, with chronic illness, MS and other chronic illnesses, anxiety and psychosocial issues are very challenging. There can be work issues. Maybe you can't work as long. Maybe you need job modifications. And just the uncertainty of what life might hold for you can cause a lot of anxiety. So that certainly has to be taken into consideration when your rehab professional is putting together a plan for you. We still struggle with lack of insurance support for ongoing rehab services. I would like to say that a lot has changed over the years, and you know, we're still fighting and doing battle to make sure that you get the services that you need. And you know, there's not just one issue that may be going on with your MS. There might be multiple issues, and so you really need somebody to kind of have a good, frank conversation with, so that you can be able to prioritize what things are most important to you and what should be faced, what should we tackle first. So there's a whole list of symptoms that are commonly addressed by rehab, and I'm not going to go over all of these. I selected a few to go over today, but remember, as a physical therapist, I can't look at this list and say, hey, I've got you covered on every area. That's why it really takes a team. You know, we have rehab professionals that are really specialists in speech and swallowing, or speech and language pathologists are key for that. They key in cognition, as an occupational therapy is. And so if you get a whole team together, you're able to tackle more of those issues in a shorter amount of time, and really have a team of the professionals that are best at what they do to kind of help you along. So we're going to talk about weakness first. Weakness is experienced by at least 50% of individuals living with MS. And weakness can be from actually the disease itself, because you have a lesion in a particular area. The messages aren't getting through your central nervous system out through the periphery and innervating the muscles correctly for you to have a full contraction or have the strength that you need. But weakness can also come from disuse, and here's a perfect example. Let's just say that you have a flare-up or exacerbation, and your level of activity decreases. So you're resting more because you need to, your fatigue is worse, and so you become more deconditioned. And then you go to do something, and you say, okay, well, I'm gonna walk down to the mailbox, and it's like, oh my gosh, I feel really weak, I feel really tired, I can't do that. And so you rest some more. So it becomes kind of this vicious cycle of that you're not breaking through that fatigue cycle to really kind of become more conditioned. So, you know, I can't evaluate somebody and say, okay, I know exactly 50% of your weakness is from MS and 50% is from disuse. But I will tell you that if we do have a very focused exercise program, we can get you to a higher level of functioning, somewhat stronger, maybe more endurance. And the factors that influence weakness are very complex. You know, you can feel weak, but you can feel weak because you're fatigued. You can feel weak because you're spastic, you have this abnormal muscle tension, and it takes more energy for you to do anything that you need to do. So they become more fatigued and you feel weaker. And sensory symptoms can play into that. Sometimes if you don't have good sensation, it feels weird, or it might feel uncomfortable for you to use a part of your extremity. So again, you're not using it to its full extent, and then you get disuse weakness. So what do we do about it? Well, exercise, energy management strategies, and use of assistive devices, and some compensatory strategies. So we're going to talk a little bit about what we can do as far as strengthening exercises are concerned. So it's really best, and you see my asterisk on the slide, you really want to be thoroughly evaluated, and that's best done by a rehab professional who has some MS expertise, because it's really important to really pinpoint the muscles that are most deficient. But not only are deficient, but if we strengthen them, that are going to give you, again, the most bang for your buck. What functional task are these muscles important for? So you can follow any type of exercise program and it will be good for you. But if you have limited energy, if fatigue is a factor for you, then you're going to want to get the most out of that energy expenditure that you use for exercise. So, you know, talking to your rehab professionals, telling them what's most important to you, getting a thorough evaluation to see which muscle groups, if strengthened, are going to help you meet your functional goals, are really what you want to do. Monitoring fatigue is important, and I'm going to give you some strategies on how to do that. In fact, I think the next slide talks about intermittent exercise. That's one way to kind of tackle this. Another thing that you want to be aware of is that if you have lax joints, if you have weakness and your joints aren't really stable, you have to really watch out for that, particularly if you're trying to use weight, so that you're not putting a lot of stress on the joint. So that's another reason why having a rehab professional that knows a little bit about MS and that can help make recommendations for you would be best. So I put this slide in here because I think that it's really kind of pivotal. We didn't have much research for a long time. I've been a therapist longer than 1994, which is this study. And so we didn't have a lot of meat to back us up about knowing that exercise is really good for MS. So this was one of the very first studies out there that really showed and really demonstrated the benefits of exercise for an individual living with MS. Because, you know, if you've been living with MS or you know the history of MS, you know, years ago they would just say, you know what, you have MS, go home, rest, kind of live in this bubble, don't have any stress. And we know now that that is not the way to go, that we know that exercise is an integral part of your overall treatment plan. So this was a study done in 1994, and they did 15 weeks of aerobic training. I think it was 2 to 3 times a week. And what they found is that the individuals with MS that did 15 weeks of aerobic training increased their aerobic capacity, meaning that they were fitter, that they were cardiovascularly improved, better endurance, decreased skin fold thickness so that their body contours changed, so less fat, more muscle. Their triglyceride levels went down. They had increase in the isometric force. That means they got stronger, and that it had a profound impact on the factors related to quality of life, which I had talked about before. So all in all, the conclusions of this study, even in 94, and we've got a plethora of more research to kind of back this up, is that individuals living with MS reap similar benefits from aerobic exercises as persons without MS. So right there, we know exercise is good, but we know that exercise is good for individuals living with MS. And it's stated clearly that exercise training appears to offset the typical difficulties of MS: excessive fatigue, depressive mood disorder, and low self-rated quality of life. So if I needed to sell you on exercise, hope that I did a little bit of a job to say, yes, this is beneficial for you. So I want to circle back a little bit, because we talked about monitoring fatigue when you're exercising, and a strategy to kind of help with that, like, Patty, I'm so fatigued, how can you ask me to use some energy to exercise? So a nice strategy for that is an intermittent exercise strategy, and a lot of work this was done by Herb Karpatkin and his crew. What they did is they took individuals and they had them treadmill walking, and they, instead of just said walk as long as you can, they gave them certain bouts. So they might have walked for 2 or 3 minutes, and then they interspersed a rest. And then they had them do another bout and then interspersed a rest. And what they found is that individuals with MS, if they exercised in this way, were able to tolerate a greater dose of walking, because that's what their study was on, if the bouts were intermittent. So again, how you apply your exercises, or how you do your exercises when you're living with MS, might have to be a little bit different. Kind of have to change your philosophy of how you might have exercised in the past. You know, we're inundated with, you know, media saying no pain, no gain. If you're not sweating Gatorade, you're not working hard enough. And the philosophy for MS rehab and MS exercise is different. You can do smaller bouts, interspersed rests, and still get the benefits of the exercise and still manage your fatigue. So that's really key. And it's key, again, I keep on harping on this, that you work with somebody who understands that can counsel you and develop a home exercise program with these points in mind. Something that came hot off the presses, I think that it was right at the end of May, that the National MS Society developed these exercise and lifestyle physical activity recommendations for people with MS throughout the disease course. It was endorsed by the Consortium of MS Centers. And there were 2 points that I pulled out of these recommendations. If you want to go on the Society's website, and you can see all of the recommendations, it's a very nice document. But there are 2 points for me that were key. And one of them is that they stated very clearly that early evaluation, so soon after diagnosis, if you can be evaluated by a physical or occupational therapist, exercise or sports scientist experienced in MS, that's what the recommendation is, so that they can set you on the right path. The other recommendation, and this is research-based, is that an individual living with MS should have about 150 minutes per week of exercise or lifestyle physical activity. The lifestyle physical activity, things like gardening or dancing or housework, those minutes count towards your lifestyle physical activity. So if you think about it, if you're doing something 5 days a week, that means about 30 minutes each day you want to devote to some type of activity. And again, it doesn't have to be continuous, it can be intermittent. So if you're looking for just kind of a general guideline of, well, where do I start and how do I get started? That would kind of be your goal. You want to take into consideration any comorbidities that you have. You know, do you have diabetes? Is there, you know, any concerns for cardiac concerns? Do you, you know, anything else can influence those minutes per week. But certainly that would be what your goal would ultimately end up being. And so I frequently get the question, this is why I put this slide in here, is, well, Patty, I have a progressive form of MS and everything talks about relapsing remitting, and what about exercise training for somebody with progressive MS? And so there's more and more literature out there to suggest that exercise is beneficial for somebody who has progressive MS. And the evidence states that you can improve your cardiovascular fitness, your muscular fitness, so strength, tone that you have, also help manage fatigue and quality of life outcomes. So if you think back to that slide that I showed you about the study with Patagian in '94, these, which are more recent studies in progressive MS, have similar findings. So very positive. So don't feel like, well, I've been diagnosed with a progressive form of MS, that exercise is inappropriate for me. The literature, the studies looked at different forms of exercise, conventional exercise training, like just strength training and stretching and aerobic training. But FES cycling, which is a functional electrical stim, I have a picture on the next slide to show you, and body weight supported treadmill training. So on the upper left-hand corner, this gal is riding a bicycle, but her arms are connected up to electrical stim. So they help stimulate the muscles so that she can perform that upper body cycling. And then on the bottom right, this gentleman is in a body weight supported treadmill. So that harness that he's in takes some of his body weight and also helps with his balance so that he can perform the activity of walking on the treadmill. And over time, they can take less weight from the harness and more weight on your legs. And again, it's another way to exercise with some modifications or adaptations. So, all right, so I want to talk about fatigue. If you're out there living with MS, you probably have experienced fatigue, because more than 90% of individuals at some time will experience fatigue, and more than 50% report that it's their most disabling symptom, that the fatigue is really what limits them the most. There's no correlation between fatigue and level of impairment, meaning that you can have limited or no physical impairment and still have a lot of fatigue. Female versus male, there's not one gender that has more fatigue than the other. MRI findings, or knowing that you're relapsing remitting or you're in a progressive form, doesn't give you any indication what your fatigue is going to be like. So, but it does moderately correlate with depression and cognitive function. So you can kind of think that makes sense. You know, if I have a lot of fatigue, I don't have a lot of get up and go, you know, I can have more emotional angst. And also we'll talk about cognitive fatigue and cognitive function in a couple of slides. And it is the main reason that individuals living with MS either leave the workforce or have to have modifications in their job. So I just wanted to kind of quickly review the types of fatigue. There's normal fatigue. You've had a busy day. All you want to do is come home and lay down on the couch and watch, you know, reruns of Grey's Anatomy, something like that. There is this neuromuscular fatigue, or what I term short-circuiting fatigue. So let's say you're walking through the grocery store and you're feeling pretty good and things are working well, and you get through the first couple aisles, and then get to the third aisle and then your legs are starting to feel heavy. And then you get to the fifth aisle and you're dragging your feet. And by the time you get to the last aisle, you're like, I need to find a place to sit down because nothing's really working well for me. And that's short-circuiting fatigue. The messages you initially are able to transmit along the nerves, but then they basically get short-circuited and you lose that ability to make those muscles contract and do the functional skills. So usually you recover with rest from that, varying degrees. If you really push it and you really over fatigue, your recovery time might be longer. Then there's that depression-related fatigue that I just don't feel like I can get out of bed in the morning, or that I have no desire to do the things that have interested me in the past. You can also have cognitive fatigue if you've ever just sat and, you know, balanced your checkbook, okay? So cognitive activity, you weren't running around the house, you weren't doing a lot of physical activity, but a cognitive activity can actually tap into your energy stores and really kind of deplete you there. And then there's a term that's kind of reserved just for MS fatigue, and that's called lassitude. It's this overwhelming sense of tiredness that isn't attributed to anything, any identifiable cause. I had one patient really explain it to me well, and she said, Patty, it feels like somebody took a wool blanket and made it wet and put it over me. She says, that's the sense that I have with my lassitude, my fatigue. My mind's willing, but my body's unable. So those are the types of fatigue. So what can we do about it? Well, want to make sure that you just don't always point the finger at MS, and I tell people that all the time. Make sure that you are ruling out anything else that might cause fatigue. And a lot of the medications that we might use for MS care, it may cause fatigue. So a good discussion with your healthcare professionals on that may be indicated. But believe it or not, light to moderate exercise is the key for fatigue management. So you want to make sure that you're incorporating a little bit of exercise. And the example I used on this one is that even if you can think of pre-MS, if you're living with MS, and you're like, okay, I don't feel like exercising today, but you kind of like, all right, I'm going to do a little bit. And then you do a little bit and you feel more energized. Well, that's kind of the same thing when you're living with MS. Plus two, you don't want to get into that, I call that circular swill that, you know, I'm fatigued, I'm not going to do anything, I become more deconditioned. It's harder for me to do anything. So you want to break into that cycle. Certainly, if you're in Florida and watching me, or many states across the country, you know, right now, it's hot. And cooling is an important thing for fatigue management. And a lot of times you may not even realize how much heat is playing into your fatigue. I treated one gal who came into the clinic in Orlando, and really we kept it so cold in there with the air conditioning. I kept on teasing Dr. Rosenberg that, you know, we could hang sides of beef in here and nothing would spoil because it was so cold in the center. But even with that cool air conditioning, I still had to put a cooling vest on her, a cold pack on her neck, and we put a wet towel on top of her head because she was so heat sensitive that in order to exercise, we had to keep her that cool. So it's just something, you know, you may not be that heat sensitive, but it's something to keep in mind. And there's some really good research out there to say that if you pre-cool before you exercise, like taking a cool shower, drinking a really cold drink, your exercise performance is better. Also for fatigue management, where you want energy management, and I have a next slide on that, but we can talk about that. You want to make sure that you're sleeping well. If you're not sleeping well, you're not going to have, you know, good daytime energy if you have poor nighttime sleep. So one of the things to discuss with your healthcare professionals are you getting up to go to the bathroom more than twice a night? Because it may not be actually your sleep, it may be irritated bladder or neurogenic bladder that's getting you up and then interrupting that sleep. So addressing your bladder might be the solution to your sleep, which may be part of the solution for your fatigue. So kind of looking at the total package. And then using assistive devices, and sometimes that's a hard discussion to have when you start to use an assistive device. But my slant on this, or my philosophy on this, is that if you can use something that's going to give you more energy or allow you to do an activity that's important to you for a longer amount of time because you have less fatigue, then that's always a plus. And you also want to have a healthy lifestyle. If you're a smoker, stop smoking. I'm not going to harp on it, just going to tell you to stop smoking. Eat a healthy diet. My little tagline is garbage in, garbage out. If you don't put good fuel in your body won't perform well for you. And one other thing that I don't have on the slide that I think is really important, and I'm realizing that now that I'm living in a really dry climate out here in Colorado versus that humid climate in Orlando, is hydration. You need to really stay well hydrated in order for your body to perform well. You can almost think of water as a key nutrient, or as a key, I don't know, medicine almost, that your body needs to perform well. So if you're not well hydrated, you're going to have more fatigue. You might have more muscle cramping, and you'll say, well, I have MS, so I have fatigue. Well, if there's something that you can do to help manage that by staying better hydrated, or less muscle spasms at night, by drinking enough fluids, then that's the key. All right, and aerobic activity is one of those things that you can do for fatigue management. Here's Terry, she's on a Schwinn Airdyne bike, which is a nice bike because it blows air on you from the fan that's in the front, and you can do arms and legs at once, or each individually. So, you want, again, to talk to your healthcare professional about, your rehab professional about what interests you too, because if I tell you, okay, swimming is the best exercise for MS, and you don't know how to swim, and you don't have a pool near you, and it takes an inordinate amount of energy for you to get in and out of a bathing suit and in and out of the pool, then that's not the best exercise for you. So you really want to have something that you can do, that you can be successful at. Energy management strategies, pacing. What do I have to do today? How do I have to prioritize it? How can I spread it out? What are the things that are most important in case I run out of steam, that those things are done, and the other things I can leave to another day? And being flexible with that schedule. Using compensatory strategies, and a lot of times people hear that word compensatory strategies and they're like, oh, that's a bad thing. And sometimes it is not necessarily a positive thing, but if you're making changes because it's going to give you more energy. For example, taking a seated shower, okay? Taking a seated shower saves 25% of the energy over a standing shower. So how important is it for you to take a standing shower if you can save 25% of the energy by just sitting down? So that's a positive compensatory strategy, okay? This is hard for many of us, accepting a request for assistance. So asking somebody to do something for you, or taking advantage, I mean, certainly in these COVID times, like ordering your groceries online and having them delivered, or, drive by and having them just pick them up on the curbside. So, things like that. Home and work modifications, using assistive devices. And the last is recognizing warning signs. There's sometimes some red flags that you can identify. Sometimes when you're really fatigued, you might notice, oh, my vision gets a little bit blurry, or maybe I get a little bit more numbness and tingling in my fingertips or my toes. And that might be the first warning sign for you to kind of identify, hey, I'm pushing the envelope here, I need to step back. And equipment, I'm not going to spend a lot of time on this, but there's a lot of equipment that your rehab professionals can help make recommendations for. And a lot of things are really easy. I have a gal that I just recently seen in the clinic here in Steamboat, and she was traveling, and she was going to her son's home, and they didn't have an elevated toilet, so it was a low toilet. So we just made a recommendation for toilet safety rails, and those clamp right onto where the toilet seat clamps, and it has two rails that come down. They're adjustable, so they sit right on the floor. you know, they were a relatively inexpensive modification. They could take them with them and then take them home when they came home. So, you know, having some recommendations for equipment is a really good thing. Wheelchairs are, again, that's a big discussion, but again, a lot of times if you can use a mobility device that will allow you to participate in an activity that you would either struggle through or that would allow you to do it when you wouldn't be able to do it at all, is always going to be a positive thing. So if you can think of it in those terms. Really quickly about heat sensitivity. A lot of folks are heat sensitive. I talked a little bit about that. The ideal pool temperature is between 80 and 84 degrees. That's a cool pool, okay? So just be aware of that. An environmental temperature, 62 to 66 degrees, which is also very cool. If you're exercising, they actually did a research study to see what was the best way to cool yourself down. And I'm not plugging Slurpees because I don't have any investments in Slurpees, but an ice drink, like an ice slurry, that's the best way to cool yourself down the fastest. So if you're overheated and you can get a really, really iced drink down you, that's a really great way to cool your core temperature. And then the next best way was lightweight clothing, like a, you know, light wicking t-shirt that you wet. So, you know, Slurpees and then wet t-shirt contest, okay? So those are the two best ways to cool yourself down. Just teasing, but yes, those are the ways. I want to talk a little bit about spasticity because many of you are facing that abnormal muscle stiffness. You might describe it as tightness, you might describe it as a spasm, and it's different than it happening at the muscle level. It actually happens because of an imbalance of impulses in your brain. We have impulses in our brain that make things work. They're called excitatory, and then we have impulses in our brain that quiet things down. Those are inhibitory. And when everything is working right, it's kind of the scales of justice. They're in perfect balance. But in MS, sometimes those scales get tipped and you have too much muscle tone, not because of the muscle itself, but because of the messages coming down from the brain. And 75% or more of individuals with MS are living with some degree of spasticity. Your spasticity can get worse if there's something else going on in your body, like an infection. I had a gal who actually had an infection in her toe from getting a pedicure, and her spasticity went off the charts, and we discovered the infection. She got treated and her spasticity went down. So kind of problem solving for something else going on is important before you just say that it's an exacerbation, which an exacerbation can cause increase in spasticity. Noxious stimuli can make your spasticity worse, like a pressure sore, if you're constipated, if you're really anxious, and even clothing that's too tight. Like if you're squeezing yourself into your skinny jeans and you really have to buckle yourself in, that kind of compression, that noxious stimuli can actually cause your spasticity to be worse. So what do we do about it? Stretching is like the #1 way. A lot of times I get referrals from the physicians to start somebody on a stretching program before they'll even consider medication for the spasticity, because stretching is really an effective way. Now, stretching is a short-term answer. Stretching once doesn't cure your spasticity. So this is an ongoing thing, so you have to be committed to it. But there are some really great medications if you're needing more than just a stretching program. Actually, aerobic conditioning is a really good way to manage your spasticity, that rhythmical movement. Positioning out of the pattern of spasticity. So a lot of times you might feel like your leg draws up or it straightens out, and positioning out of that, getting some weight on your extremities, sometimes relaxation techniques, and orthotics like positioning devices to kind of help you maintain that position and not cause the spasticity to take over. So I just wanted to put a slide in here about stretching, because stretching is really key, but stretching should never be like a bounce, no bouncing in stretching. A long static hold, 30 to 60 seconds, but you only need to do a couple of repetitions. And again, you want some help to determine which muscles, if they're stretched, are going to give you the most bang for your buck. And there's just a therapist stretching somebody out. I'm not going to spend too much time on this because I think that you guys have had some really good lectures on pain already through the MS Foundation, or they're upcoming. But pain was really never recognized until the 80s that it was problematic in MS. You were told it was a painless disease. But we know that that's not true. The good thing is that pain is not a predictor for a poor disease outcome. And the pain can be because of the disease itself, or it can be because of some secondary problem. So the types of pain that I usually see in the practice are what we call dysesthetic pain. It's that nervy, I don't have a good medical term for it, so I'm going to call it icky. It's that icky, nagging, burning pain that you might feel. It can be in your extremities, you can have it in your trunk. Spasticity can cause pain. And then you can have musculoskeletal pain because of poor positioning or that you're not using your muscles correctly. So a good physical therapy evaluation can help with that, identify the source of the pain or what can be done, particularly exercising, position changing, some modalities. I don't use heat just because of the heat sensitivity, so that's why I put ice up there. And prevention, being aware of what might provoke your pain and avoiding those things. And along with the pain, there's those sensory symptoms. Included in that can be hypersensitivity. I have folks tell me like, oh my gosh, the sheet just touched my legs that night and it just sent me through the roof. And there's also that band-like sensation around your thorax, around your trunk, which we fondly, not so fondly, call the MS hug. You feel like you're being squeezed. Those are all part of the sensory abnormalities. Remember, your nerves are two-way streets. There are part of the nerves or part of the messages that come down from the brain and the spinal cord that control your muscles, but you also have messages that come up from the periphery, from your joints, from your skin, that tell your brain that something's hot, something's cold, something's sharp, something dull, all of those sensory things. So either one of those pathways can be affected by MS. So that's why there's sensory symptoms in MS. So what we can do about that, certainly you want to talk with your medical professional about any medications that are appropriate. And I do something called sensory retraining. You know, there's some really good work in the stroke rehab that talks about when someone has a stroke and they don't have good sensory feeling, or their sensation is not normal, that doing a lot of providing a lot of sensory stim can actually help access different parts of your brain to kind of recover those sensory feelings again. So, you know, using a washcloth or using, using lotion and doing some massage, just providing the area that's not feeling well or feeling right with a lot of sensory stim in order to help access different parts of your brain or send the messages up to your brain in the right amount and the right intensity so they're interpreted correctly. Certainly movement through exercise is important, and knowing about, you know, how to manage some of that, the educational piece of that is important. So my last slide is just to talk about wellness behaviors, because I think that it's the total package of what you do. Rehab is important. Rehab can help you take charge of managing your symptoms. That kind of gave you a quick overview of some of the things that rehab can do. But there are a lot of things that you can do that you can take charge of your own health. And even having this diagnosis of MS, you still can be healthy. It does not mean that you're ill, that you're sick. So doing good wellness behaviors are really important. Don't smoke. Start exercising. A little bit is better than nothing, okay? And you've got to start somewhere. I'm always pleased when somebody just tells me, hey, you know, I walked to the mailbox today. That's a good start. Eating a healthy diet. We could talk all day about diets. There's one thing that I like to recommend, and that is, would your great-great-grandmother recognize what you're eating as food? So if you held up a Twinkie to her, would she say, yeah, I know what that is, and that makes good sense to eat to me? Probably not, okay? So kind of whole foods, unprocessed foods. Manage the stressors in your life. That doesn't mean that you don't have to have any stress in your life. We all have stress, and even good things can be stressful. But being able to kind of take it in stride, manage it, let it move through you so that you're not kind of wallowing in it. Positive attitude doesn't mean like, yay, I'm so happy I have MS, but it's just that, okay, I'm going to be grateful for what today brings me and what positive things can I find in my day-to-day. Being an active part in developing your medical plan is really important, and being able to follow through with that so that you're not being told what to do, that you're actually helping develop it, and that way it makes you feel empowered. Don't forget to continue with your well visits. So don't forget to go for your regular dental checkups and your OB-GYN appointments and your regular primary care, because just because you have MS doesn't protect you from having anything else. And a lot of the things that we kind of brush off or might say, oh, I have MS, so it must be that, can be dealt with. And one of the things that you're already doing just by tuning into this webinar, this podcast, is that you're educating yourself, and that's very, very empowering. So I'm going to leave you with a picture of where I hiked this past weekend. This is up on a path called Devil's Causeway on Rabbit Ears Pass, up near where I live in Steamboat. And I feel very, very grateful every day for this beautiful land and beautiful environment that I live in. So with that, I'm going to stop yammering on, and Casey is going to moderate some Q&A for us.
All right, thank you so much, Patty. And I would hardly call it yammering. So let me let our audience know how they can get their questions in. There are a couple of different ways that you can ask questions. You can enter them in the chat, or you can use the raise hand feature. Using the raise hand feature is very easy, but it depends on which version of Zoom you are using. So if you are using a mobile device, you're going to touch the screen. It's going to bring up your menu, and you are going to find it under the More menu with the ... So you're going to press More, ... and raise hand. If you are using a computer, you're going to find it under the Participants menu. So you'll click the Participants window, and at the very bottom, you will see an option to raise hand. If you raise your hand, I will bring you on the line, and you will get a message on your screen asking you to unmute. If you want to use the chat feature to ask your question, again, you touch your screen or click your screen, and you'll see a little speech bubble that says chat, and you can type your questions in there. All right, so we have a question from Myrna about how often to see a physical therapist. She wondered about going once a month. She said, I find during the 6 months I've not been able to go, my physical abilities go up and down. Would going once a month be better to keep you in check?
So that's a really good question, and that's a really nice discussion to have with your rehab professional when you start out. I usually, when I evaluate somebody, we talk about what the plan of care is going to be, and usually we'll start out maybe with once a week because we're trying to develop a home exercise program, address any of the issues that might be on the priority list, and then we'll decrease frequency. So quite often I might see someone once a month, so that I've given them their home program. You go back home, you're working on it, you come back to see me, and I can say, hey, listen, this is the progress that you've made. These are the areas that are still concerning for us. Let's modify this, and then send you off again. You know, some of that is dictated by insurance coverage, but if your therapist is documenting a well thought out and well developed plan of care, I have been very successful in having the insurance companies cover you in a plan that is seeing you just once a month. So, again, everybody's an individual, so have a discussion with your rehab professional because it should be tailor-made for each and every one of you. Just because your neighbor goes, once a week or 3 times a week doesn't mean that that's what's appropriate for you. So make sure that you have that discussion, and that's, and again, I want to kind of really promote that you are an active participant in this. So what your needs are and what your thoughts are and what you think that needs to happen in your care is important, and it should be voiced. So
our next question is from Janelle. Janelle?
Hi, can you hear me?
We can hear you. Go ahead.
Okay. I have a question about when I go to the physical therapist, they only address what the doctor has sent me there for. So if I've got a problem with, I don't know, my arm, then that's the only thing. They don't do a combined thing to say, okay, this is what you're going to do to stay active, or you're going to do to, they don't do my whole body. They just do
Right.
one thing.
Yeah. So what I have worked with the physicians that I work with is that they will write the prescription for therapy, evaluate, and treat. So that gives me the latitude to do, in my professional opinion, what is best for you and be able to address you comprehensively. So yes, I understand that if the physician had written like right arm only, then that's what we're obligated to do under the physician's prescription. And if I receive a prescription like that and I feel that there is more to be done, I'll request a new prescription from the physician and ask him or her to write, evaluate, and treat so that I can deal with you comprehensively. That's the only way to go because MS doesn't limit itself, to one joint or one extremity. There's a lot of things that go on, even though they may not be problematic at that time. So addressing the whole person is really key.
Okay, I don't want to be like I'm in a press conference, but I got one more thing.
Go ahead, Janelle.
Walk away.
Thank you. I swam, and then after COVID happened, the pools are closed.
Yep.
And so I'm trying to actively find another one that has a chair that goes down. So there are a lot of things that were thrown at us to try to overcome.
Right.
To keep busy, to keep moving. So I don't know what else to do. I just keep trying, I guess.
Yeah. This is a really, I hear this over and over the last 4 months, Janelle. One of the things that I've done to try to stay connected with my folks that have had opportunities or have barriers to being able to exercise in the community is that I'm able to do telehealth visits. So if you have a connection with a physical therapist that's able to do a telehealth visit, they can help you establish a home exercise program if that wasn't established, or help problem solve some other means of exercise for you. But it has been a challenging time. I understand that.
Thank you very much. That's a good idea, because that's a good idea. I'll look into that. Thank you.
Reach out. Yeah, absolutely.
Thank you very much, Janelle. All right. Our next question is from Almeria. You should have the option to unmute yourself now.
Okay, can you hear me?
Yeah.
We can hear you.
Okay, hi, how are you? I'm from Puerto Rico, and I am already in a wheelchair, and I want to know if you have if you recommend any visual exercise program that I can do it in my house, because right now I don't want to go out to anywhere.
Yeah, I don't blame you. And
Okay.
like we spoke to Janelle, one opportunity for you is to have a telehealth visit, so someone can connect with you like we're video chatting. And although the evaluation becomes a little bit more difficult, I have done them via telehealth, and I can get kind of a good idea of what you might need, and then make recommendations, and then check back with you via telehealth, once a week, or, maybe a little bit more at the beginning, and then spread it out over time. But that's certainly been an option for us in this COVID time. And I know that there have been a lot of barriers to even going into places that we would consider, safe places like a hospital outpatient. You just don't want to go out, and I get that. So, video conferencing is a great way to kind of make that connection.
Well, I don't think that we have in Puerto Rico that available, but because I have a good doctor specialized in MS, but I went to Health House and they don't really know exactly about MS. They treat me overall, but not exactly what I want.
Yeah. Well,
or what I need.
We have the same issues, if you live in a more rural area and you don't have access to care. I always suggest, find out who is doing MS in your community, ask the service organizations if they have any referrals for you in your area, so that you can connect with the right people. So
thank you.
You're welcome.
I appreciate it. I will.
Okay, and we have some questions in chat. So one moment, let's see. Deborah asks, can you suggest an exercise to alleviate pain from MS hug?
Oh, and that MS hug is really a difficult symptom. So usually what I do is a multi-pronged approach. Stretching the trunk, which a lot of people don't address the trunk. So doing some stretches for the trunk. Also, I had talked a little bit about the sensory retraining. So a lot of times what I give out are little soft brushes, and being able to go in that area where you have that symptom, and either doing some deep pressure or doing a little bit of brushing with the soft brush sometimes can help send different messages up to your brain, and your brain starts going, oh, she wants me to feel this soft brush or this deep pressure. And that, I'm not saying that it's the be all end all, but I've had some good results with kind of the sensory retraining. Stretching the trunk, overhead stretching. If you're working with a physical therapist already or a rehab professional, then you might ask them for some trunk stretches. If you're familiar with any of the yoga poses, child's pose is a really nice one to get into the trunk, and a side child's pose where you walk your hands to one direction and hold, and then the other direction and hold. But again, you want to be working with somebody, you want to make sure that you don't have any spine issues, that's an appropriate exercise for you. So if you're working with a rehab professional, you might ask for them to make some recommendations.
Okay, our next question is from Gregory. Gregory, you're on the line.
Can you hear me okay?
Yes, we can hear you.
Now, I'm actually one of your Orlando patrons. I never met you directly, but I am in Orlando.
Hi, Gregory.
My question is, and I don't know if you've run into this before, I'm a disabled veteran, and the problem that I'm having is that the therapist says I need to have 2 or 3 sessions a week because of my spasticity and the way that I have the locking of the muscles at all times. The VA, my primary at the VA has told them that we need 2 to 3 per week. The problem that I'm having though is on the administrative side, they're saying, well, we only get paid per lump, not per visit. And so they've limited me to 1 per week. Have you run into that before? And do we know?
I have, yeah, I have. First of all, thank you for your service.
Oh, thanks for recognition.
Very grateful for that. So that's a tough one because we are still bound by whatever the limits of the insurance company are. In a situation like that, what I've done in the past is I've gone on my letter writing campaign, my calling, really good documentation about why this is needed. I have occasionally been able to get an insurance company to come outside the limits of their benefit. Not often, but that doesn't stop me from trying. So if you can encourage, inspire your healthcare team to advocate for you, and you advocate also for yourself. It sounds like you are an advocate already for yourself. But I flood them with documentation about why this is appropriate and why it's needed. Sometimes in the meantime, you have to kind of go along with the plan because it's usually a slow process and you don't get answers quickly. In those type of situations too, I always look to the community if there are any other resources in the community that could help augment your therapy. So in Orlando, what I used to do is petition the PT school and ask if there was any PT students that would like to volunteer, if you needed a stretching program, if they were willing to kind of come into your home or meet you somewhere just to provide some of the basics of what you needed. So, discussing with your therapist if there's any community resources that you could access to kind of augment what you're able to get through the insurance. Good luck.
Thank you very much for your question, Gregory. All right. Patty, we do have a few more questions in chat, but I know we are coming up on our time. Are you on a strict schedule?
I'm not. I have my nephew here who's homeschooling and he's been really good, so.
All right, so let's try and knock out a few more of these for our listeners,
absolutely.
if you don't mind.
No, not at all.
So Deepa asks, what about bladder control issues? Can rehab help with that?
Thanks for asking that question, because there is a whole subspecialty in rehab that is bladder retraining and bladder management. There is a whole, and I'm not a bladder specialist, but there are therapists who are. And so the use of electrical stim in order to help augment the muscle control of it, time voiding, a lot of education. So yes, if you can ask your healthcare provider to have a referral for bladder management to a specialist there, that would be really helpful, yes.
Okay. Jennifer asks, regarding spasticity, can it feel like sore muscles? Sometimes I've woken up and my calves and quads feel like I did a hardcore workout the day before when I didn't.
Yeah, well, they did do a hardcore workout because spasticity actually causes a muscle contraction, okay? And the same thing happens when you're exercising, you're causing a muscle contraction. Now, I don't want to confuse that with, oh, spasticity must be a good thing. If the muscles are contracting, I'm going to get stronger. That isn't how it works, because that muscle spasticity is an involuntary contraction. And what you want for strengthening is a voluntary contraction. But if you're experiencing some spasticity, you can feel really sore, you can feel really stiff, you can feel achy. All of those things go along with muscle spasticity. So, a suggestion for that, particularly if you wake up feeling like that, is before your feet hit the floor, if you can wait to go to the bathroom, then doing a few stretches in bed to kind of help prime the pump, get things loosened up, might be really beneficial to how you feel for the first couple hours in the morning.
Okay. And our final question here is
water. Sorry, drink water.
our final question here is from Kay. Kay says, I drag one of my feet slightly. I've been diagnosed with arthritis in my lower back, which is very stiff in the morning. Could the dragging in my foot be making my back worse?
The simple answer is yes, because if you're making a compensation in how you walk because of the weakness in your foot, that goes right up the chain, okay? Yeah, I laugh because I always think, whenever I say that, I think of that song, the ankle bones connected to the knee bone or whatever that one is. Nothing is an isolation in itself. So if you have to make some compensation for some weakness in the foot, and you might be hiking your hip, or you might be swinging your leg out a little bit, or you might just slightly change the way that you put the weight on one leg versus the other. That can have a profound effect on what's happening in your back, because it goes right up the chain. So, addressing the foot problem may not be the total answer to the back problem, but if you can get some relief from that, that would only be value added. That would only be a plus.
All right. So thank you very much. And before we close, I just want to make a few housekeeping announcements. If you missed any part of this presentation or would just like to watch it again, it will be posted after a period of review on the Foundation's YouTube channel. I've put the address of the YouTube channel in the chat for anybody who would like to know where that is. We recommend that you subscribe so that when a new video is posted that you get a notification. We do have more upcoming Zoom conferences. The next one will be on August 20th. The topic is Thrive While Trying to Survive, Strengthening Connection, Purpose, and Joy in Difficult Times, and that'll be presented by psychologist Laura Steppelman. We hope that you'll be able to join us. For information about times and access information for future teleconferences, you can visit msfocus.org and click events, or follow us on Facebook, Twitter, Instagram, all the social media, we're out there. So again, I'd like to thank you all for joining us. We really appreciate your being here. We appreciate your questions and participation. And especially, I'd like to say thank you to Patricia Bobryk for being here with us today and presenting this wonderful and helpful information to our audience. Thank you so much, Patty.
My pleasure. Thank you for having me.